We're going to do a demonstration of a navigated SI fusion. A couple of things about workflow. So the way that I set it up is I'm on the side away from the operator for the O-arm. I don't know if you can see that. I don't see what you're seeing yet. Then the workstation or the tracking arm is at the foot, and then I stand on this side. So we've got a perk pin in, and I think, can we see that? Can we see the perk pin here? They're working on it. So when you put in a perk pin, a couple of comments. The cluneal nerves come across this area, and that I usually palpate the posterior superior iliac spine, make a small incision, and then use a Kelly clamp and spread down so that you try not to catch the cluneal nerves, and that makes it a little less likely to have a neuroma problem from there. Then I obtain a spin, which we've already done, and so now I will use a nav probe to give me some guidance about where I want my start points to be. This is a dysmorphic sacrum. It's not horribly dysmorphic, but it's a little bit dysmorphic. And if we can, who's doing my stealth monitoring for me? I need to zoom out just a little bit, if you could, on that for me.
So Dave, point of clarification, by dysmorphic pelvis, that's exactly the same thing as a transitional vertebra, correct?
Yes, in varying degrees,
okay.
but yes. Okay, and so you guys can see that nav screen, and you see that upslope mammillary process on the axial image on the bottom left. And so that gives me a warning that I've got a problem in that area. So when I'm doing my placement, I literally have to talk to myself, and I say, all right, I need to move more cephalad, okay? And then right now it's going out of frame, and so I need to angle more anteriorly. I need to be more cephalad still, okay? And so now we're looking at that upslope, so I need to move my hand towards the foot. Okay, now I need to move my start point down a little bit. Okay, and now I'm starting to get into the area that I want to see, and if I angle up a little more, bring my start point a little more caudal. All right, and okay, and so now we can see that I can put that in at a reasonable trajectory. So I just mark the skin, so this is sort of entry point number 1. Okay, and then I will find my next entry point to go to more of a S2. All right, and I see that I'm fairly off here, so I need to be more cephalad. And when you've got that cranial angulation, start point number 2 may actually be above start point number 1. All right, so what I want to do is get it in a through and through trajectory. So I need to be more posterior. And again, I literally do talk myself through this and use that language. And so that's probably what I want for a second implant, maybe just a touch caudal, okay? And I could get I can go all the way across right there. And this patient may only be able to accept 2 implants. That's the way the transitional segments are. And so I'm not upset by that. It's just sort of, it is what it is. 2 are supposed to be enough. 3 is better when you can get 3. But this is what this patient's going to give us. So then I'll inject my local anesthetic. I'll make my skin incision, and got to do a little bit of modification. I usually use the short drill guide. We only have a long drill guide here today, so we'll figure out how to make that work. So long drill guide, and I need a long K-wire. So there are some very long K-wires that exist for doing through and through screws. It just makes it a little bit harder to get our views when we're trying to check it, and so that may be a little bit harder today. Okay, and all right, so this is more of my, okay, so I need to be, all right, so I like that a bit. So
this is a navigated drill guide. Is it like made specifically for this purpose?
No, it's just a universal navigated drill guide.
Got it.
Okay, and so we're going to have a little trouble taking our check x-ray, but we'll try that right now. So if you guys can give me an AP of the pelvis here, and I'll hold this K-wire, so you just got to watch. You can't go to the preset on this one. So we usually preset everything to be able to, all right, and then give me a little bit, good, hold it right there, that's as far as you can go. And then give me a little bit of gantry tilt, top towards the head. about 15 or 20 degrees or so. Maybe a little more if you can. All right, and then give me so let's put the big light on top so that we're going PA. So big light on top, we got the little light on top now. And your techs, as they get good at this, can preset the positions, and then we move fairly quickly from one to the other. Anytime you do a demo, you get to sort of figure out different things. So we're not quite all the way around yet. There we go. Okay, and image. All right, and I don't know if we can flip that image or not, but we see that what I see on this is that it is going into that accessory area. I might tilt it a little bit more. I would, if I'm critiquing this, actually I might start it just a little bit more caudal, and in fact we can do that. So robotic towards the head, please. And then do we have another K-wire? And so we'll leave this K-wire in. So if you can park that at the head for me.
So Dave, you did a spin at the beginning, and then you're getting another fluoro shot just to take a look at the depth and the direction of the wire, right?
I'm a big fan of Ronald Reagan, trust but verify, and that that allows me to make sure that things are, so as I double check myself and say, you know, am I happy with what I achieved or not? And so now I'm going to take my navigation again and look at where I'm going, and that says I need to be a little more posterior and a little more posterior still. And so what I found on this navigation part is that what you really want to do, you can't navigate accurately until you're down on the bone. And so when you're in the soft tissue, you're just not going to get great information. So you got to dock your drill guide on the bone before you can really get a lot of information out of it. And so I've got pretty good, I can't tell if that's frozen bone or end plate there. And so now we'll go ahead and get another quick image on that. Okay, that's good. And shot. Image, please. All right, so that says I haven't crossed the joint yet, which explains the resistance. All right, so park the O at the head. And that's not surprising. Using slightly different K-wires, and so I'm not judging my length as well as I would with the other K-wires that I normally use. So I need about another 20 millimeters in there.
Why not just use live fluoro here?
Well, you can. So I use the O-arm routinely, and so rather than change out, we just use it because then it can give us, they've got presets, and so they can go back to exactly the same position. And so that is an advantage. And I guess it's really truly robotics because it's the robotics of the O-arm.
Got it.
But, okay, so that pin is exactly where I want it. Does that show up well? Let's park it there. Okay, all right, so now we're ready to do the steps, the other steps of the procedure. So Eric, if you will take this K-wire out. Sure. So, and you're gonna have to reverse. So you gotta squeeze this, you gotta squeeze that, and then the reverse. That's forward, so that, yeah, so.
Yeah, it's locked.
Okay, and we have to figure out our drills, which.
Yeah. Is there a switch or something? Okay.
Yeah, so these are threaded tip pins, so you've got to have it on reverse to be able to pull it out. All right, so now what we use is a soft tissue dilator, okay? And really complicated maneuver. And it's now dilated, okay? So now we're ready for the, I call it the 3-in-1 guide. And I have a, so this is an asymmetric, non-cylindrical device. So I put my first one so a flat side is towards the head, and that way they can be nested a little better. That's an arbitrary pattern that I use. So now we're going to use the drill. So did we template that out? We didn't. It'll probably be about 60 or 70 implant. So we'll put the nav drill guide back on in a second. This is cannulated and it tells me the depth. I've got to drill through the inner table of the sacrum in order to get into the soft bone, but you don't have to drill to the nominal depth of the implant. And then typically with the shorter pins, I'll have to use a switching stick in order to... Okay, so the trick here, may I have a mallet, please, is that all of them can sort of bind up a little bit into the driver, and so you need to not lose your pin. Where's Larry Koo when you need to talk about K-wire and pin management, or maybe Michael Wang, both of them. All right, so,
I like K-wires.
all right, so now I'm ready for the broach, and this is a navigated broach. So this broach, we have to show the eyes to the tracking station, and then this will show me exactly where we're going. So Eric, if you don't mind going over to the other side and providing a little counter pressure, this, this specimen is having a little bit of a challenge. Okay, so we should be able to see on the navigation the depth now of the broach going into place. Okay, and we can see it's a little posterior from where I optimally want it to be. I think it'll be okay. All right, and so I'm at about 50 millimeters, 45, 50 millimeters now. Okay, and so that would be a reasonable length implant. I could probably go 5 longer. So I don't know if we've got a 55. If we do, I'll take it. Otherwise, I'll take about a 60. And then same thing about not losing the pin. Okay. So now we're ready for the actual implant. Okay, so this is a 55 millimeter implant, and the orientation again needs to go the same way that it did before. And then this is a navigated impactor, which will give me a sense of where the depth of things are. Okay, and so now we'll, okay, and we get a sense of where it's going, and the nav is showing a little bit different from the original plan, but we'll see what that looks like. And some of that is the variability of just impacting it. And so I'm not entirely sure which is exactly correct, but we'll check it. Okay, and so when I'm hubbed, I should now be down. Okay, all right, so let's take a quick AP image. All right, and it does not look like this pin has advanced. That looks like that's what we want. So leave that in that position, and then give me a 20-degree oblique going that way. And I need to take the reference frame off, or it won't show up so well. Okay, well, maybe I won't. It's fighting back. Okay, image. More oblique, more towards you. And so this is other way.
Sure. What do you think?
That looks good. All right, shot. All right, and so now we see a profile view of the ilium, and that suggests that it is down in the appropriate position. And then I've got to pull this K-wire, so if I can have the driver, and then we can do inlet and outlet views with max tilt both ways. To check it, which is how you would do it under fluoro. And then what I do routinely is to take a 3D image at the end. Okay, all right, so now if you can give me max tilt in both directions. And so this is what you would do with fluoro. And the fluoro units, looks like we're up against the base of the table. So that's all you can give me. So why don't you give me that shot? We're still in the oblique. We need to be, so bring it. So the comment about O-arm versus C-arm, you could do it with C-arm, and it just takes a lot of C-arm manipulation. Okay, now let's tilt max the other way. And so on the AP projection, or actually a Ferguson projection, that looks good. It doesn't tell me the anterior-posterior position of it.
So on that view, you're looking at kind of almost like a face-on view of the sacrum, right?
Yes, it's a true AP of the sacrum.
So essentially, it's like a pelvic inlet view.
Yes.
Yeah.
So so we may have to lower down in order to tilt more. Is there room to lower down? Looks like there is, yeah. Okay, all right, and then more tilt. And so now what we want is an inlet view. Okay. All right, and so that's not a great inlet view, but what I would do now to check it, what I would do now to check it would be a 3D spin after I got all the implants in. And then if I don't like it, I can take it out or change it. So why don't we just go to a lateral real quick, or however quickly we can do it. So again, this specimen represents that dysmorphic sacrum, which actually makes it a lot tougher to do and to judge. And so that looks okay on the planar imaging. And again, I would do a 3D image. So let's go back to the park position. And now Eric Heyman is going to show me his skills. And he's going to help with the second one. And I'm going to try to talk him through that. And he tells me he's never seen or done this before. And, and so that we're going to, so if you can robotic towards the head. Okay, and so the second start point was this one. Yeah,
more,
yeah.
A little more caudal.
Yeah, so just go ahead and dock it on the bone.
Yeah.
There you go. Okay, now let's look at the navigation. Okay, so drop your hand towards the floor.
Yep.
Okay, all right. And so as I look at this, we want to be a little more caudal.
Okay.
Okay, so back off, and let's come caudal. And I just hope we haven't messed up with the reference frame. So hand towards floor, and hand towards floor, hand towards floor. I'll tell you direction to move your hand. That's just what we found works better. So when I look at this on the screen, what I'm seeing is we're going into the frame, and we don't want that. So we need to move more caudal to come into this area. And then we want to see a line all the way across, and we want to go across there. Okay, so that's pretty close. So hand towards floor a little more.
That's not saying there, right? That's
okay, all right. And I would start, so now come a little more dorsal for your start point.
okay.
Okay. All right, a little towards, a little caudal.
That's not right.
Yeah, and so you just dropped into the sciatic notch is what happened there. Okay, so now bring your hand towards the foot a little bit. Okay, and you see how that's a nice shot. So you can go ahead and advance that. And you're not going to get, you need to back off on you need more length on this. So just sort of, about that much length. Okay. All right, take that down, and you'll feel resistance, the outer table of the ilium, the inner table of the ilium, and the outer table of the sacrum, and then it'll get soft, and that's when you're into the sacral bone.
Thank you.
No, you slipped. Okay. All right, so release your grip. Okay.
Okay, reverse to advance it.
Oh, okay. Hold on, you're slipping. There you go. Good. Okay, maybe just a little more. Okay, that looks good. All right, so now come off with your nav, come off, and let's take that Ferguson view real quick, and we'll see how that looks. All right, an image. Okay, so sometimes you can't see real well because of the gas that's present, and that's the case in this specimen, and that's where navigation actually is very helpful. Can we get any more tilt than that?
Absolutely.
Yeah, it's banging up against the base.
Yeah.
Okay, so try Yeah, all right, let's shoot that, and then we'll stay with that. And so then we'll repeat the steps, and then go from there. So let's park the O-arm. Let's have the soft tissue dilator. Okay, and do a 360 on that. Okay, now we're ready for the 3-in-1 drill guide. The 3-in-1 guide. Okay, and so the first implant we put like this. This one I put the second implant flat side towards the ceiling. And that way, if they're close, the triangles will nest with each other. All right, you got to dock that on the, so do what you got to, there you go, okay. And the specimen's trying to make that, yeah. Okay, all right, so now take the center slot out. Okay, and here's the drill, and let's drill it to about 45 or so. And again, you can pre-template these. In my usual workflow in my OR at home, the person running the nav screen has given me a measure off of that typically.
Thank you.
So you're at 20?
Yes.
Yeah, keep going, keep going. And you'll feel that difference as it gets soft. And there you go, it just got soft. Did you feel that difference there? Okay, all right, so now we need to back that out.
Okay.
So we want to hold the pin. So give me a mallet. And so sometimes if the pin is hanging up, so I'll just tap like that. So now just pull back on the drill. Just pull back and see if it'll slide. Sometimes it will, sometimes it won't.
It's not coming easily.
Okay, so there you go. Good, that's coming. Yeah. That's come on out. Keep coming, keep coming.
Yep.
Okay, and then there you go. Perfect. All right. So now we're ready for the broach. All right, and we got to put the broach so it can be seen by the nav. Right, which means it's either got to be that, and that's probably what's going to do it. Okay, and then you're going to use this slotted hammer, and then you're going to impact it. You got to pack around the K-wire. So, okay, and let me hold that for you.
Thank you.
So get down to about 25 or 30 before you even bother looking. So go, 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 go. There you go. Hold on, and now let's take a look at it.
Yeah.
Okay, and that gives you a sense of where you are.
Yeah.
And so you can probably move your hand towards the floor a little more.
Yeah.
And so what's happening is this.
The table.
Yeah. There you go.
Okay.
Right. Okay.
Oh.
Okay.
Not true.
All right. So let me see if I can take over for just a second and see if we can. So we've got some mobility in here that is throwing the nav off a little bit, but that's all right. So what we're going to need to do is make the 3-in-1 not be the constrainer. All right, so what I would do at this point, so what's happening is that normally on a Jackson table, we're not constrained with this handle, and this handle is constraining us a little bit with the table. So we should be able to track that. That looks reasonable. Okay, so go ahead and take it down to about 40, 45. I'm going to hold the handle for you. Okay, all right, so that's 40, all right, so that's just barely across the joint, so let's take it a little further. So let's go to 50. And we can put in, we can put in a longer implant than that. So probably, I'd go with a 50 at this one, maybe actually 55. And so now we've got to take this out, so take the broach out.
Okay.
So slap that out while holding the K-wire, and you can even use your lead to put your belly up against the K-wire. Not that that's ever happened before. If you had a bigger belly, it'd be easier to do, but as you get more senior and more experienced, you'll get a bigger belly.
Okay.
I don't know if that's a good thing.
Eric, you need to beef up.
I know.
All right, that looks good. Okay, now let's take the navigated impactor.
Okay.
Okay, mallet. And
Where'd the mallet go?
And then this goes until it's flush.
Okay.
Okay? All right, and then what I do at this point is I take all of this out, I leave the K-wire in case we need to change something. It just makes it go a little faster. All right, now let's take a quick Ferguson view there and see how we look. And if that looks okay, then we'll pull the pin, then we'll do our inlet-outlet views. All right, and can we get a 2D image maybe? So I did want to comment a little bit about what had been talked about earlier. So when we started using O-arm and stealth at our institution, we made the decision that we were going to use it on cases where we didn't need it so that our workflow was good on cases where we did need it. And I think that that's important, whatever you're going to do. Don't start any new technology. So we have that K-wire advancement that I told you about.
Okay.
So we'll go ahead and pull that K-wire out now. Okay. So this one's coming out easily, all right, which says a little bit about the bone stock. Okay, now let's do our inlet and outlet views if we could, guys. And then maybe a lateral. And so it seems like we ought to be able to get another implant in the middle there, but on these dysmorphic sacrums, sometimes it just won't happen. And so that's, I think that's real world. So, okay, so we're not quite caudal enough. I got an idea. Let's do this. All right, and shot. Okay, so that gives us an image. Okay, now let's go the other direction. And what I'm looking for is the neuroforamina. I see the first ventral neuroforamina very clearly. I don't see the second or third very clearly. And that's the gas distribution in this specimen. All right. And next. And we're not getting a really great inlet view to really tell us if we're out the front. It needs, okay. And unless you're used to pelvis trauma kind of images, it'll take you a while to appreciate these images. So we need to robotic towards the head a little bit. All right, and shot, okay, all right. And so if we get a more of an inlet view, then you can judge that anterior cortex. Okay, and let's go to a lateral. And then I think we'll be done with this presentation.